Welcome back, everybody. Today's topic is GI bleed, mostly upper GI bleed, gastrointestinal bleed, upper gastrointestinal bleed. So, this usually uh, occurs with the symptoms of hematemesis or melena. So, coming to GI bleed, we have the upper GI, also the lower GI, right? So, how do you divide whether the bleed is from upper GI or lower GI? How do you actually differentiate the whole gastrointestinal system into upper GI and lower GI? So, this can be done with the help of a ligament called ligament of Treats. So, this particular ligament divides the entire GI tract into upper GI and lower GI. So, from here it continues. So, the ligament of Treats, it connects the fourth part of the duodenum with the crux of the diaphragm. So, if this is the esophagus and this is the stomach, this is the duodenum, this is the first part, second part, third part, and the fourth part. This duodenojejunal junction is there, no? So from here, the ligament of Treats connects this part of the duodenum to the crux of the diaphragm. So this particular ligament divides the entire GI into upper GI and lower GI. So when the bleeding occurs, it can be either due to upper GI tract or the lower GI tract. So, what's the definition? Definition of upper GI bleed is bleeding proximal to the ligament of Treats. Okay. So this ligament of Treats is a suspensory ligament where fourth portion of the duodenum transitions to the jejunum, as we saw here already. Okay, so what are the etiology? Etiology of upper GI bleed. So above GE junction, GE is gastroesophageal junction. So above the gastroesophageal junction, we have epistaxis, esophageal varices, esophagitis, esophageal cancer, and Mallory-Weiss tear, etc. Mallory-Weiss tear. So, what is gastroesophageal junction? It's the junction where the esophagus continues as the stomach. I'm so sorry. So, my stomach has. Okay, wait. So, where the esophagus continues as stomach. So this is the gastroesophageal junction. So about the gastroesophageal junction, the causes of upper GI bleed will be epistaxis, esophageal varices, esophagitis, esophageal cancer, Mallory-Weiss tear. So how the patient presents in case of upper GI bleed, which is above gastroesophageal junction. Usually the patient presents with hematemesis, which means nothing but vomiting blood, right? Vomiting blood. It can be either very abrupt blood, like like, splash on pan, we call it, that happens usually in case of hemorrhoids. But we can actually compare it with this too. Just for the comparison, I'm just saying here that hematemesis can occur like splash and pan, so that kind of vomit can be there. And also there can be coffee ground vomitus, because of the reaction between the blood and the acid which is secreted by the stomach, so it can happen like that too. Or there can be presentation with malina. What is malina is dark tarry stools. Why does this occur? So when the patient bleeds from the upper GI, the blood gets oxidized. So when it takes that long time, it undergoes oxidation and results in dark tarry stools. So this is malina. Okay. So what are the main causes of upper GI bleed above gastroesophageal junction? So it can be epistaxis. What is epistaxis? It is the bleeding from the nose, right? We all know that epistaxis. So when the person swallows that blood, he can regurgitate the same blood, and it can present as hematemesis. Or any bleeding from any vasculature from the esophageal region can also be called as epistaxis due to hypertension and various other connective tissue disorders, etc. This can happen. And also we have esophageal varices. Esophageal varices occurs secondarily due to portal hypertension. So we have liver here. So whenever there is liver cirrhosis, there will be portal hypertension leading to variceal vasculature in the esophagus, also in the stomach. Okay, so the collateral circulation. So whenever there is portal hypertension, there will be secondary varicosities in the esophageal veins and stomach veins. So this can occur, and this can lead to further bleeding, giving rise to esophageal varices, which leads to upper GI bleed. Then we also have esophagitis. Esophagitis occurs due to recurrent GERD or reflux diseases. So that can actually erode the whole mucosa and submucosa of the esophageal region, also the stomach region. So that can lead to bleeding. So that can cause erosive gastritis or erosive esophagitis, can cause upper GI bleed. Also the esophageal cancers. So whenever there is esophageal cancer, there is increased vasculature in the cancer growth, which leads to spurting of blood. That can happen. So esophageal cancer is also one of the causes. And what about Malarivoestia? Malarivoestia occurs due to increased retching or forceful vomiting against a closed glottis. So that can eventually lead to a lesion here in the mucosa of the esophagus or the stomach region, leading to bleeding. So that lesion can tear the vasculature, and that can cause upper GI bleed. So these are the important causes above the gastroesophageal junction. Now coming to causes from the stomach region. From the stomach region, same thing usually. Additionally, we have gastric ulcer. As we have already seen in esophageal, erosive esophagitis, we have erosive gastritis, right? Gastric cancer. And here's one more interesting thing, which is gastroantral, we call it as GAVE, GAVE, which is gastric antral vascular ectasia. It is rare, but no, usually it is associated with cirrhosis or connective tissue diseases like Ehlers-Danlos. Ehlers-Danlos. Usually these patients can come with GAVE. So on endoscopy, you can actually see the stomach wall as, watermelon stomach. We call it as watermelon stomach due to due to vascular ectasia. So all the vasculature will be very prominent in the gastric mucosa. So which is nothing but gastric antral vascular ectasia. This can cause bleeding, upper GI bleed. And what about, and we have one more, which is Dieulafoy lesion. It's pretty rare. Dieulafoy lesion, where there is arteriovenous malformation, so that can lead to a single vessel, prominent vessel, which comes above the mucosal region, and it is more prone to lesions that can lead to increased purgative bleeding. Okay, so this can happen in Dieulafoy lesion, leading to upper GI bleed. What about duodenum? Now here one more thing is gastric ulcer. Gastric ulcer, peptic ulcer disease can cause bleeding, upper GI bleed, because it ruptures, disrupts the entire mucosa and submucosa, leading to exposure of the vasculature underneath, leading to upper GI bleed. This can happen. So these are the causes from the stomach. As we have already seen in erosive esophagitis, we have erosive gastritis, and similar to esophageal cancer, we have gastric cancer. Additional to that, we have GAVE, which is gastric antral vascular ectasia, and Dieulafoy lesion. What about duodenum? So we have duodenum. Causes from the duodenum. Again, we can list down one of the causes as peptic ulcer disease, PUD. Also, we have, there is one more life-threatening cause, which is aortoenteric fistula. If the patient presents with profuse hematemesis or hematochezia, so we should suspect aortoenteric fistula. This patient has to be seen on an emergency basis, right? So what is aortoenteric fistula? We know fistula is a connection between two entera, right? So this fistula connects aorta. Aorta is the major blood vessel in our body. Aorta to gut. So that is duodenum. So when the fistula connects aorta to duodenum, what do you think will happen? The blood coming into aorta will flow into the GI system or gastrointestinal system, which is nothing but the gut. So the patient will be profusely vomiting blood or profusely passing blood in his stools or just bleeding from per rectum. So that is hematochezia. This is a danger sign. You need to rush towards the patient and rush the patient to OT, because this is very major issue. If this happens, the patient will be no more in a few hours, right? Because of loss of lots of blood. So this is a very dangerous case, aortoenteric fistula. Usually it will go into CTVS people, cardiovascular people. Usually this happens in patients who have the previous history, who are status post some kind of aortic graft or something. So as a complication, they might end up with aortoenteric fistula. Okay, this is one major case which you have to keep in mind before ruling out the causes for profuse upper GI bleed or hematochezia. What are the other causes? Other causes can be just coagulopathy. Patients with, patients with coagulopathies, increased bleeding time, decreased clotting time, defects in PTINR, PTA, PTT, some kind of liver disease or renal disease who are on heparin therapy. So in all these patients, upper GI bleed can occur due to coagulopathies. Okay. And we have vascular malformations. Vascular malformations, as I've already mentioned, dual-ophoid lesion, or some kind of arteriovenous malformations. Okay, so this is about etiology. Now, how do you go about management? So whenever the patient rushes to ED, or when you're practicing, the patient rushes to you and with the complaints of increased vomiting or bleeding from rectum or vomiting blood, etc. So these symptoms have to be further evaluated. Also, there can be passage of dark tarry stools, melena. So everything has to be evaluated. Initially, what do you do when the patient rushes to you? You check the vitals. You find out whether the patient is stable or unstable. So the patient comes with complaints of vomiting of blood, and you see there is drop in BP, increased heart rate, cold clammy extremities. What do you suspect? Patient is stable or unstable? He's definitely unstable and he should be seen on an emergency basis, right? So when he's hemodynamically unstable, go for IV lines immediately. Okay, so 1 to 2 large bore IVs, rush IV fluids, monitor his vitals. This is the first thing you need to do when the patient is unstable. Okay, so the unstable patient has to be stabilized first. Okay, do this first. So when you go for 1 or 2 large bore IVs, get the blood samples for, what do you send to see his blood picture? You go for CBC, which gives you RBC counts and platelet counts, etc. HB. So if the patient has undergone severe bleeding, this will be decreased, right? So if he has immense bleeding, so all these will be hampered. So RBCs will be low, platelets will be low, HB will be low. So go for CBC, then PT, PTT, INR. So coagulation profile has to be sent. So if he is on heparin or he has liver disease, renal disease, you never know. So you need to find the cause for upper GI bleed. So you need to send coagulation profile. Okay. Then you send electrolytes, BUN, suspecting any renal disease, or if as we know, when the blood volume is low, even the kidneys will be hampered, right? So what about acute renal failure? That can occur in such cases because of immense bleeding and decreased blood volume. There'll be less GFR, leading to acute renal failure. That can happen, giving rise to increased BUN. So BUN has to be sent, create has to be sent along with BUN, LFTs has to be checked. Next procedure is, not procedure exactly, the patient has to be kept. NPO, don't give anything to the patient orally. Okay, nil per oral, or we say nil by mouth. Don't give anything to him oral, because already his, mucosa is ruptured, or vasculature has been ruptured in his gastric mucosa or esophageal mucosa, or throughout the entire GI system. You don't want to bother him with some food, etc. It can lead to sometimes it can lead to aspirations. And also you need to keep the patient NPO for further evaluation. You need to evaluate what's the cause, so you need to go for endoscopy. Upper GI endoscopy has to be done. So for that you need the patient nil per oral. So you need to keep the patient nil per oral. This is one more main thing. Okay, insert NG tube. Insert NG tube, nasogastric tube. Okay. This can be used to determine whether the bleeding is from upper GI or lower GI. You can do that. There's a method, there's a procedure where you just sprinkle water into the gastric region, and again suck it back, and you find the volume of blood collected, and you can actually determine whether it is from the upper GI tract or the lower GI tract. So NG tube has to be inserted. Then what else? So keep the patient NPO, NG tube has to be put. You give IV proton pump inhibitors. They decrease the risk of rebleed. Proton pump inhibitors decrease the risk of rebleed. Alright? And also it stabilizes the clot. What else? So now coming to the main cause, which is nothing but variceal bleeds. Here you have medical therapeutics. Okay, so rest everything has to be done under endoscopy. But here, if definitely you need to confirm it's variceal bleed through endoscopy, but after that you can go for medical therapy. This involves octreotide, IV octreotide, 50 microgram loading dose continued by 50 microgram of infusion. Okay, 50 microgram per hour infusion has to be given. 50 microgram loading dose and 50 microgram per hour infusion. Along with this, you give antibiotics. You don't want any infection to happen when there is exposure of mucosa, submucosa, and this vasculature. You don't want the bacteria to enter into the circulation. So you always have to give antibiotics in such cases to reduce the risk of infection. Usually you give ciprofloxacin or ceftriaxone. Okay. Then what else? So consider IV erythromycin. Metoclopramide, to accelerate gastric emptying. Okay. So the main thing to be done in such cases where there is upper GI bleed is nothing but endoscopy. Endoscopy has to be done in each and every case. So if it is to find the cause, you need to find out, right? You can't see the patient and just assume, so this might be the cause, that might be the cause based on his symptoms. No. The upper GI bleed or the lower GI bleed has to be evaluated further. You can't just stop the bleeding and just sit calmly. You can't even stop the bleeding unless and until you know the cause, right? So you need to go for endoscopy. So the main agenda of endoscopy is to determine or establish the bleeding site and treat the lesion. So if it is bleeding peptic ulcer disease, what do? So you need to control the bleeding first. So you give injection epinephrine. You give injection epinephrine, injection epi near the lesion, around the bleeding point. You can just inject around the bleeding point. Okay. And also you have the option for thermal hemostasis. But using the bipolar electrocoagulation or heater probe, you can just go for thermal hemostasis. Okay. And you can use endo clips. Seeing the bleeding site, you can just go for endo clips. Hemospray or other dual therapies. You can go for intervention. Usually esophageal varices. In esophageal varices, you can go for dual therapy. You give medical intervention with IV octreotide. You can also go for band ligation or sclerotherapy. For other causes like malarial dulophobous lesion and peptic ulcer disease, you can go for endo clips, hemospray. All these options are available using endoscopy. So you just locate the lesion and treat the lesion. It's as simple as that, but you need to be a professional, right? So yeah. What about the prognosis? So peptic ulcer disease usually heals. You give something called CAP, right? Proton pump inhibitors, antibiotics. There's a combination. There's a particular schedule to treat the peptic ulcer disease. And you can endoscopically you can treat it using injection epi. It heals. The thing with the varices, esophageal varices, can rebleed. So rebleeding rate is quite high in case of esophageal varices. It happens due to liver cirrhosis. So the liver cirrhosis has to be treated first. It has to be treated, okay, finally. But you can actually predict the bleeding. You can actually predict the rebleeding rate in case of esophageal varices using a classification system called Forest classification of rebleeding in case of esophageal varices. So how do you classify? There are 5 classes: 1A, 2A, 2B, 2C, and 3. What is 1? So if there is arterial bleed, the bleeding is evident. There is spurting or oozing of blood in endoscopy. The risk is very high. Risk is 55 to 100%. There is increased risk. In case of 2A, what is it? Okay, so this is class 1. Class 2A is visible vessel. There's no actual bleeding or spurting or oozing of blood. But you can see the vessel. You can see the vessel on endoscopy, vessel which is bulged and which is about to bleed. So this kind of vessels can be seen. So that is class 2A, 43% of chance. 2B is sentinel clot. There is just a clot near the lesion. There's a clot. There's no bleeding happening or there's no engorged vessel, but there's a clot. So the possible chance of rebleed is 22%. And 2C has hematin covered flat spot. Just hematin. There's like a scar, a reddish scar over the lesion. So this has around 10% chances. What is 3? 3, no stigmata of hemorrhage. So this has 5% chance of rebleed. So this is Forest classification. This is important. This has to be remembered. So yeah, this is about our upper GI bleed. So to summarize, you can make a flow chart. So there is overt GI bleeding, okay, which is hematochezia, hematemesis, or melena. So there is overt bleeding. If the bleeding is yes or no, there is no overt bleeding. Uh, so it can be upper GI bleed or so I'm sorry, wait. So if there is over GI bleed, you can go for upper or lower GI endoscopy, right? Endoscopy. So you found the source of bleeding. Source of bleeding. If yes, if you have found the source of bleeding, just treat it. If no, go for wireless endoscopy capsule or double balloon endoscopy. So there is overt GI bleeding, the patient is present with hematochezia, hematemesis, or melena, you go for endoscopy, right? So it can be either upper or lower GI endoscopy. And if you find the source of bleeding, if you find it on upper GI endoscopy, just go and treat it. If no, then it can be due to lower GI, so you have to go for wireless endoscopy, okay? Then if there is no overt bleeding, rule out non-GI sources of bleeding. If the patient has anemia, just treat it, just follow up, okay? So this is a summary. Yeah, that's all for today. Thank you.